we can finish up the head and neck slide set we started early last week.
Awesome. Thank you. So let me full screen this, unless it already is. There we go. Okay, cool. So we have, we went through the original neck and ear. So we're gonna start on the sinonasal. Again, I will share the full presentation with the IHCs after this, once we're done with the whole set. So does anybody have any questions from last time, or are you guys pretty good on what we saw last time?
No questions here.
No questions. Okay, great. So let's start with this case of a sinonasal mass. And so again, I think if nobody volunteers, we're going to call on people. So please volunteer. Happy Monday. Who hasn't spoken yet?
Let's see, everyone's still waking up.
I know. How about, who's on there? Christine. Hi, Christine. You're coming to Surge Path.
Yep, it's my first day.
So you get the benefit of at least describing what you see.
Well, at low power, there are several pieces of tissue. They have more of a basaloid appearance. As they zoom in, potentially they look somewhat glandular.
Good.
Some of the cells I can see nucleoli.
Anything about this material in the center?
Is that mucinous material?
Well, something's in the center of
yes,
these
something is
glands,
in the center.
right? Okay. All right. Anybody want to give a hand?
Technical word for the stuff in the center is crap. It's sort of like necrotic slough. There's some inflammatory cells in there, but it looks like sort of ghosts of cells that maybe have sloughed up the epithelium.
Cool. All right. So we have multiple fragments. So this is some kind of fragmented biopsy of a glandular proliferation, right? It's these sort of spaces with cells at the periphery and a lumen in the center. And the glandular proliferation has little almost projections into the lumen, like maybe small little papillary projections into the lumen. And the nuclei are elongated with somewhat cleared to kind of vesicular to somewhat granular chromatin. There's lots of mitoses. Here's one right there. Yes, and then there's this material in the center, which I would argue is not mucoid, because it doesn't have a bluish kind of grayish appearance, but it's like fragmented cells. There may be some vacuoles in the lumina of these, toward the lumina of some of these glands in the apical cytoplasm, but they're not overtly like bluish mucin, but they kind of look like they maybe could be. So does anybody more senior want to venture a guess as to what this might be, or what stains you might want to confirm in this, what this is in the sinus?
Hello. This kind of reminds me of like an intestinal type adenocarcinoma, and I want CDX2 and CK20 maybe.
Okay, tell us about intestinal type adenocarcinoma while I show you the stains.
Oh, okay. Well, it kind of looks like what we see here. It's got like those pencillet type nuclei that kind of remind you of like a tubular adenoma or something like that. And supposedly leather dust and woodworking kind of stuff like increases your risk for it. Although it can occur sporadically too.
Excellent. So I'm showing you the CDX2. As you can see, right, I'm showing you the, oops, sorry about that. I'm showing you the control, right, which is normal colonic mucosa. And here's nuclear CDX2 transcription factor in the nucleus of the normal colonic mucosa. And so in exactly this tumor, which is intestinal type adenocarcinoma. There is in fact nuclear expression of CDX2, and there is, next, cytoplasmic expression of, what did you ask for?
CK20.
Yes, CK20, thank you. So, sinonasal intestinal type adenocarcinoma is in fact a very characteristic kind of clinical pathologic correlation of a tumor that essentially looks like a colon cancer. Usually looks like a colon cancer or an intestinal type cancer with very elongated nuclei, with very complex branching glands, with grungy debris in the center. And you can confirm with characteristic immunostains that would otherwise also stain colon cancer, right? So you have to exclude that. Whenever we make this diagnosis, we sort of say, does the patient have colon cancer that could have metastasized to the nose, because that happens, or and does the patient have some kind of occupational exposure history, like wood dust, leather dust, usually some occupational, because, oh, sorry about that. No, I'm not gonna answer Elizabeth Blair. I'm teaching right now, sorry. Okay, so it is these patients, characteristically kind of middle-aged to older males, that have these occupational exposures that get this type of cancer. Anybody have questions or comments? This characteristically can appear on the boards because of the very classic clinical pathologic correlation. All right, sorry.
Also, for everyone that's on, just a reminder, 8:45, all the search path people, please stay. We updated the schedule, so we'll do a quick search path meeting.
Yeah, Melissa, are you going to be able to run that? I might be.
Yeah, I can run that. Not a problem.
Thanks.
All right, thanks guys. Sorry for the interruption.
That's fine.
Okay. Sinus number 2. Description.
Ooh.
Maybe somebody junior, like maybe Mia, can tell us what is perhaps different and or similar compared to the first.
Yeah, I was going to say that this looks similar to the last one. We have these nests of darker blue cells, and there is some sort of material in there, but it doesn't look necrotic like the last one. It maybe looks like some sort of actual material. Maybe those cells are secreting.
Okay. And nuclei, how are the nuclei different?
The nuclei have nucleoli, and they're cleared out.
Mm-hmm. Are they quite as elongated, or are they maybe a little more plump, oval, round?
Yeah, they look very plump.
Mm-hmm. Mm-hmm. All right, so in this case, we have, again, a somewhat gland-forming lesion, right, with some material in the center that's maybe not quite as grungy neutrophilic debris, although, yes, there's a couple neutrophils. This actually looks like it could be sort of myxoid or mucoid or even serous type of material. Again, with a complex architecture, with dilated, with some branching glands. But the nuclei are quite different. They're not as elongated. They're not as cleared and vesicular. They have small nucleoli, and they don't appear to have as much of those apical vacuoles as the other one did. So any comments on what kind of lesion that this might be? There's maybe some almost like snouting here at the surface. So does anybody have a differential diagnosis for this lesion?
I mean, it could still be a sinonasal adenocarcinoma, kind of like the one that Heather had described, just a different phenotype.
Okay.
Because there's multiple types besides the intestinal version of it.
Okay. So what are the other types?
Do we have any papillary formations or
You tell me.
Let's try. Yes, maybe we have. Yes, maybe we have papillary formations here. So it's kind of tubular formations and papillary formations. Here it's micropapillary, maybe.
And what does that tell you, or does that tell you anything?
It's adenocarcinoma, sinonasal adenocarcinoma, maybe mixed type, or are we able to call it papillary? Intestinal type, mixed.
Okay, so intestinal type mixed. So what stains do you want then?
I would do P53. Is
What's
that
that
correct?
going to tell you?
Mutation for.
And is that going to tell you a diagnosis, or is that just going to tell you whether it's P53 mutated?
No, it wouldn't tell me the diagnosis.
Right.
I would do CK7 and CK20 and CDX2 as well.
All right, so in this case, I am going to tell you that the CDX2 and the CK20 are negative, but here is, yes, I think someone already typed in there, CK7. All right, so bless you. When you have adenocarcinomas of the sinonasal cavity, right? You can get squames everywhere. We're used to seeing squames, right? So what happens when you see a glandular carcinoma? So in the sinus, you want to think about a few of the more reasonably frequent ones, including the non-intestinal type, the intestinal type, and then just a random salivary gland carcinoma type, right? So remember, you have salivary glands all over your aerodigestive tract. So don't ever forget, number one, that you can get a salivary gland type adenocarcinoma anywhere in the upper aerodigestive tract. In the sinonasal cavity, you could get intestinal type, which we've seen, and you can get non-intestinal type, which in fact is this, okay? So if you're thinking, could this be an intestinal type? You can prove it by morphology and by immunostains. We can show by CK7 that this is not an intestinal type, okay, because it has the converse immunoprofile of CK7 positive and 20 and 2 negative. And if it doesn't have any other obvious salivary gland type morphology like mucoep or salivary duct or things like that, you can probably call it a sinonasal non-intestinal type. And so that's in fact what we call this. Does that make sense? Arguably, you know, some might say, oh, does this look like a polymorphous or cribriform adenocarcinoma of salivary gland? Somewhat. I do think that there are some resemblances to that. And that is where genetics might come in handy if you really want to navigate the differences between a salivary type and a non-salivary type sinonasal adenocarcinoma. But essentially, that's what we're dealing with. What is one of the more important features that we can, at least, what is one of the more important parameters that we should give for all glandular type carcinomas of the head and neck? What are they going to ask you? Besides the subtle, is it cancer A? Is it cancer B? If it's non-squamous, what are they going to ask you?
I mean, I don't know if this is, but I feel generally people ask for like mitosis rates that for high grade, low grade, maybe.
So they're going to ask you grade, right? So all of those things go into grade: mitotic rate, necrosis, PNI, LVI. You know, we don't really grade for squamous because we don't find that histologic grade is useful. But for adenocarcinomas, we do grade. And so always we would want to sort of estimate a grade for our adenocarcinomas. And I would argue that by default, the intestinal type are essentially considered high grade, and that sort of manifests in the amount of grungy necrotic material, the high amount of mitoses, the high amount of pleomorphism. The non-intestinal types can be a little bit more difficult to grade because they're not quite as overtly pleomorphic, perhaps not quite as overtly mitotically active, but you certainly can see some in there. So these are going to be perhaps a little more challenging, and there's some guidance as to grading these in the literature. But essentially just something to think about in the back of your head. I'm not going to go and grade this right now because I do think it's challenging, but you know, I don't think it's obviously low and I don't think it's necessarily obviously high. So maybe something like intermediate, but that's not always a good answer. All right, you guys have other questions or comments? Okay, next. Sorry, I finally have the chat up, so I'm reading what you guys are saying. I didn't have it up before. Okay, I saw something about PAS with diastase. What would that be for?
I thought these like the secretions and will highlight and then probably give us some sort of like direction, because like when we start off with like CK7, CDX2 and CK20, that also can I just thought about this, like these secretions, and maybe that might help.
So what would the PAS diastase tell you about the secretions?
It would be PAS positive and diastase resistant.
Okay, and what material would that be? Anybody? Yeah.
Mucin.
Mucin. Okay. So something that is PAS positive and resistant to diastase. So usually that's why two slides are given to you, right? One is PAS without diastase, without amylase. Two is PAS with diastase or with amylase. What does the amylase or the diastase digest out?
Oh, protein.
What kind of glycogen? So it digests out glycogen. What remains? What is resistant? There are two things that are resistant. One is mucin, the other. This applies to salivary. This applies to pancreas. Anybody?
Amylase?
Like lipid.
Alpha 1?
So Anyway, it's somebody said zymogen. It's the zymogen, it's the intracellular pre-digestive enzyme granules that are resistant, as well as mucin, okay? In this case, whatever this material is extracellular. And so, sure, it might be mucin, but it's kind of useless unless the material, when you're trying to identify the histologic type of a tumor, whatever material you're trying to identify should be in the cytoplasm. So, if you're trying to identify mucin in the cytoplasm with a mucicarmine stain or a PAS diastase, it should be intracytoplasmic. If you're trying to identify zymogen granules in an acinar type of morphology, it should be intracytoplasmic. So arguably telling me that this is mucoid material doesn't really help me, because you can have a lot of mucoidy types of materials. And without it actually being expressed in the cell cytoplasm, it's less helpful. So when you have, for example, you see now we're getting to the weeds. When you have a salivary type secretory carcinoma, the secretory material in the lumina stains, but there's no intracytoplasmic mucin or no intracytoplasmic zymogen granules, but there's secretory PAS positive stuff in the lumen of the glands. So arguably you don't really care about the extracellular stuff as well as you care about the intracellular stuff. Okay? Because you want to be able to differentiate the actual cell. You less care about the material that's
Okay. Makes sense.
So Dr. Cipriani, we call this sinonasal adenocarcinoma non-intestinal, non-salivary type, and then we grade it.
Yes.
Okay.
Excellent summary. All right, next case. Still in the sinus.
This one looks very pale on low power, still very pale when zooming in. Glandular, like almost follicular, and then composed of kind of a monomorphic population of cells that are very cleared out, foamy, pretty large nuclei, but without any atypia, any mitosis of note. And I mean, if it's what I'm thinking, there should be like fibrovascular separation of these groups of glands too. But I mean, it looks like some things you see in other places, like like renal cell. So definitely like a renal cell, like sinonasal adenocarcinoma comes to mind. Yeah, and here's some of the fibrous septations. So. And then that vascular too, like you expect that as well. And you do see some of that vascularization.
All right, so we have sort of nests and almost follicle-like structures of cells with very clear cytoplasm, kind of round oval nuclei, little nucleoli, and then, yeah, there's some sort of delicate vascular septation. So you mentioned sinonasal renal cell carcinoma-like. How are you going to differentiate that from true metastatic renal cell carcinoma to the nose? Rule out MET, exactly. What's your best stain going to be to rule out MET?
I mean, I know you get like CK7, CA9, but I don't know if that's
positive.
PAX8?
PAX8. So in fact, PAX8 is actually the best discriminator. So these look like clear cell renal cell carcinoma. They occur in the nose. There's CA9, I believe maybe even CD10 positive, but they are PAX8 negative. And so that is going to be the discriminator between a true renal and a renal-like. And so weirdly, there are a lot of tumors in the nose that can mimic other carcinomas, and these are two of them, intestinal and renal. You know, I don't have them on this particular slide set, but I can give you examples of others that sort of mimic Ewing's, that mimic adenoid cystic. The nose can do a lot of weird things, right? So if you have any additional interest in seeing any of those mimickers in the nose of some of these very rare tumors, let me know. We can look at them, or if we have time at the end, I can pull up my other slide set. But yes, this is sinonasal renal-like adenocarcinoma. I don't have an immuno here because this was not an in-house case. But does anybody have questions or comments? Okay, good. The sinus is a very weird.
Oh, I have a comment, Dr. Cipriani.
Yes.
Oh, I also read something that was surprising, that RCC is the most common MET to the sinonasal tract. That was surprising to me.
I don't know. You could be right. I know it's the most common MET to the thyroid, but it very well may be to the sinus. I don't know.
I read it from the head and neck book that we have in the Nessa Weiss book. Yeah.
Okay.
So,
good.
Surprising.
Good. Thanks. All right. Next case.
I can try this one.
Thank you.
If no one else has taken it. There seems to be a glandular proliferation, and these glands are lined by respiratory type epithelium. But there also seems to be like goblet cells within those glands. And if we look along the surface, at some points, it sort of looks like that outer respiratory epithelium is invaginating into the, I guess, submucosa. And so I was thinking it was a sinonasal hamartoma.
Okay. What is the full name for them, and what are the features that you might expect?
So full name, respiratory epithelial adenomatoid hamartoma. And the features that I would expect, well, I guess one is that invagination from the surface epithelium into the submucosa. And the goblet cells within the glands.
Okay.
And the increased like stroma, the fibrosis that separate these glands.
And all right, so I agree with your description. So you see an invagination of surface columnar ciliated respiratory type epithelium, which can be very complex, can be surrounded by more eosinophilic basement membrane-like material, which is what I'm sort of trying to point out here. The other proliferative feature that you can sometimes see in the stroma is actually a proliferation of these small sort of acinar-like glands that don't necessarily appear very serous or very mucinous, but kind of nondescript kind of little microacinar proliferations. So those are kind of the main histologic features that you would see in a respiratory epithelial adenomatoid hamartoma. So tell me, anyone, what is the characteristic location and kind of clinical background in which these exist? And what are they? Why do we care? Are they benign, malignant? Neither. So are they tumors or not tumors, first of all? You called it a hamartoma. What's a hamartoma? Who wants to define?
So it's not a tumor.
Yeah,
it would be a hamartoma is something where it has all the normal things that would be in that location, but they're in like an abnormal configuration.
Exactly. So it's not a tumor. It is an abnormally formed proliferation of things that are normally present in that location. Exactly. Okay. So what is the characteristic location of the respiratory hamartomas? Anybody know?
The posterior septum.
So sort of. So these tend to occur on the kind of hanging down from the olfactory areas. So they tend to be bilateral, sort of supero-posterior pedunculated things hanging off the bilateral olfactory cleft areas. They tend to be very firm and kind of rubbery and different from chronic sinusitis, although they can happen in the context of chronic sinusitis, especially in kind of middle-aged to older men. So it's this characteristic like olfactory cleft, bilateral hanging down thing in older men. And this is what you'd see. And sometimes they send them for frozen because they just look weird. They're going in there for sinusitis. They're not expecting this. And they send this to you. As long as you can tell them it's benign or, you know, non-neoplastic, that's great. Sometimes the diagnosis of RHEA ends up coming only on the permanent sections when we get to evaluate all of the tissue, especially if what they send for frozen is very small. But this is characteristic of one of those respiratory hamartomas. So it's different, arguably, from a sinonasal inflammatory polyp because the inflammation in the stroma is very, very minimal, right? In an inflammatory polyp, you'd expect there to be a lot of stromal edema, a lot of stromal inflammation, and perhaps not quite as marked of a respiratory glandular proliferation, whether it be the large columnar glands or the small little microacinar glands, okay? All right, excellent. Comments or questions on that one? All right, next. So I added an extra slide here. Both of these are the same patient. So we can start probably with the one that I think you guys may have already seen. Based on, I'm going to ask, so I know I've talked to a lot of you guys about this structure, just based on this tissue that's floating off here on the side, where, oops, why do I keep minimizing this? Where are we? What is this structure that's off on the side? Or at least someone describe it to me.
This is respiratory, and we have bone. So it's maybe sinus, nasal sinus.
Okay, and what's between the respiratory and the bone?
This is blood vessels maybe here, and then we have epithelium with a stroma.
So what particular structure in the nose and sinonasal cavities is respiratory mucosa or of bone, but these very prominent muscular vessels in the stroma? I know I've talked to some of you about this already.
Oh, mic's not working.
Anybody? Bueller?
Hello.
Bueller?
Oh.
Heather Smith put turbinate.
In the chat. Yes. Oh, my mic isn't working. Sorry. Excellent. Thank you for saying that. So for some reason it didn't pop up that there was a notification in the chat. Awesome. Turbinate. So this is particularly the structure of turbinate. So when you see these thick-walled muscular vessels underneath respiratory epithelium, often with bone, this is turbinate. So this is an entire turbinate, right? You could sort of see the structure with the core of bone, with it wrapping around, right? The function of the turbinate is to warm and moisten the air as it comes in, so that when it hits, you know, your nasal pharynx and down into your respiratory tract, it's not, you know, cold and dry. Hence it's so vascular, right? Because as these vessels dilate, they send out heat, they send out moisture. Okay, great. So this is specifically turbinate. So we kind of know where we are based on seeing the turbinate. And so we at least know we're kind of in the forward nasal cavity, right? We're not in the nasopharynx, which is where we might see something like adenoid. We're not necessarily in the sinus because the turbinate's a little too far forward. We're in the sort of nasal cavity. So then we have this lesion that is next to the turbinate. So if you think about the anatomy of the nasal cavity, right, you have the septum in the middle, you have the turbinates on the side, and the turbinates are kind of sticking off of the lateral nasal walls. So just because I can, I'm gonna just take 2 seconds to draw this, right? So lateral nasal wall, septum, it's deviated, lateral nasal wall, right? Turbinate, 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 superior, middle, inferior turbinate. All right, so this lesion, anybody wanna try to annotate where they think this lesion might be? I think you can annotate on the drawings. Do you guys have that option?
I don't think we've ever tried it, actually.
Yeah, is this something you're doing? Is this Zoom overlay, or is this something in the Path Presenter you're doing?
It's Zoom.
Oh,
so if you click on your more options, you should see something that says annotate. Yes, woo, awesome. It's fun, right? So somebody draw for me where they think this lesion is coming from. Is it coming from the, there should be a little, is there a little ellipsis, a little dot, dot, dot? Those are your more options. If you're full screen, sometimes, okay, good. Somebody, yes, you wrote septum. So you think you're labeling the septum, or you think the tumor is coming from the septum? Okay.
From the mucosa, maybe.
So there's mucosa on the septum, there's mucosa on the turbinates,
Yes.
and there's mucosa on the lateral nasal wall. So which of those three? We have a vote for septum. We have a vote for turbinate if it's sort of floating off. But the turbinate seems to be pretty intact without expansion by the tumor. All right, so maybe if we get the, I'll tell you it's not the turbinate, it's either the septum or the lateral wall. And maybe if we get the diagnosis, we will, I'm gonna clear everyone's annotations. Is that okay? Clear all drawings. Okay, so we'll come back to the location in a second, but first you're gonna tell me about the tumor. Anybody
Okay, I
want
can do this one.
Mm-hmm.
Okay, so here, as you said before, we have both respiratory, but then there's also a very thick squamous epithelium as well. And then when you go look at it, yeah, I see some like infiltrating, I guess, neutrophils there. And it does look acanthotic or like thickened.
Mm-hmm.
And then when we look at the architecture of the entire lesion, yeah, there it looks really thick. It has like an endophytic growth pattern. And then in the center, there is like multiple areas of what looks like they're kind of like the flames are like falling apart, and there's also some like keratination debris and maybe some necrosis. And here it is in the, it looks like it's in the bone actually there.
Mm-hmm. Mm-hmm. Okay, so what's your diagnosis? Good description.
So then, because of the endophytic growth pattern, I wanted to call it a sinonasal, inverted sinonasal papilloma.
Mm-hmm. That's it, period, next case.
Well, then I was also looking for, because I know that these can be associated with carcinoma, but I was looking around, but I didn't see any like definitive areas of invasion.
Okay.
There's a lot of mites here.
Yep. So sinonasal papilloma, inverted type, agree. So before we move on, let's go back to where we think the location then is. What's the most common location of inverted sinonasal papillomas? Septum or lateral wall?
Lateral wall.
Lateral wall. All right, so this is a lateral nasal wall tumor. So it's like on the thing that the septum, that the turbinates are stuck to, right? So the turbinates are coming off of that lateral nasal wall, but the tumor is starting on the lateral nasal wall and diving sort of outwardly rather than the turbinates, which are sort of popping inwardly, yeah? So we already had a comment on the increased number of mitoses, absolutely. We have a comment on the presence of keratinization, certainly. And maybe if you look at any one of these given nests, if you flip it top to bottom, like I can't tell what's what, right? So to me, this is at least some kind of suggestion of severe dysplasia or carcinoma in situ. And this is the exact problem with these sinonasal papillomas is that, oh, look, here's a ton of pleomorphism, right, kind of towards the center of this keratin debris, and yes, invasion to bone, exactly. So when these sinonasal papillomas, so in this case, the relatively benign part of the sinonasal papilloma, as mentioned here, is this kind of thickened squamoid to transitional type of epithelium with little neutrophilic microabscesses, very bland. This is your regular papilloma, all right? Then we have some excess hyperkeratinization here, this kind of spiky, which is a little bit unusual. And then this spiky, unusual proliferation just turns a corner, right, and transforms to this very, very blue, very mitotically active thing that's bursting into bone. And so, unfortunately, these sinonasal carcinomas, when they invade, don't always invade in these single cell nests that we look for in other carcinomas, right? In this case, it's percolating through these bony trabeculae, but what's percolating through these bony trabeculae doesn't look benign, right? This essentially looks like the equivalent of, to me, some kind of carcinoma or carcinoma in situ. But this is what a lot of these invasive carcinomas look like, is this very, very broad-based invasion. I don't think that anyone would expect a benign papilloma to necessarily have this deep, 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 deep atypical invasion into bone. So this is carcinoma. What were there things that were confusing to you guys on this case, or was it pretty clear now after seeing it? So here is how it works, right? So here is the septum. Excuse me, the septum is not in this picture, excuse me. Here is the turbinate, right? That's coming off of the lateral nasal wall. Here's the turbinate with all its muscular vessels. And then you go to the lateral nasal wall. And here, right, on the epithelium lining the lateral nasal wall is where you see this early little papilloma with neutrophilic microabscesses. And you also see it transform, right, to this malignant thing with keratinization, with atypia, carcinoma X inverted papilloma. Yeah, so this is a rare example, but a very, very florid example of the kind of things you're looking for when you see sinonasal papillomas. Always look for a transition to dysplasia / carcinoma in situ, because if it starts to show features like this, these are the kind of things that are going to be worrisome for ultimate recurrence, ultimate like true invasion, which is what you see in this case. Okay. Comments, questions? It's 8:44. I know we spent a while on each of these cases, but hopefully it was helpful. And if you want additional sinus like unknowns or something, I can give them to you guys just to review on your own or ask me questions or whatever. Anything else? Somebody's buzzing. Did I hear that, or is it just me?
I think it's someone else's microphone. We occasionally hear it on other.
Okay. I see something in the comment that says HPV is associated with recurrence. Is that a comment or a question? And do you want to tell us about why you think that, or should I? Comment. Okay.
Oh, I read that. I just thought that maybe it was important, but maybe it's, I don't know.
So what is the most common etiologic factor in inverted lateral wall sinonasal papillomas?
Is it HPV association?
No. Anybody else?
Is it chronic injury?
Mutation.
I heard EGFR mutation. That's the correct answer. So the ones that are on the lateral nasal walls like this are more commonly EGFR than HPV. The ones on the septum are more commonly HPV, and they in fact have an exophytic rather than an endophytic growth pattern, but it's all kind of splitting hairs. So the HPV associated ones tend to have an exophytic growth pattern. The EGFR ones tend to have an endophytic growth pattern. The HPV ones on the septum tend to have lower risk of recurrence and lower risk of cancer because of their exophytic growth pattern, and they can be excised more easily, right? The ones with the endophytic growth pattern have a higher risk for recurrence, we think, and carcinomatous transformation, we think, because of their endophytic pattern and they're hard to excise. So I think we did do the HPV testing in this one. I think it was negative. I don't think we did the molecular. So I would anticipate this to probably be EGFR. So in fact, maybe Unless I'm not reading the literature correctly, I believe that that is the breakdown. Speaking of HPV, since we're on the topic, if you have an HPV associated one, either on the septum or rarely in the lateral walls, which type of HPV, low risk or high risk?
It's usually
I think it could
low
be
risk.
both.
It's usually low risk, isn't it?
It's low risk. It's 6 or 11. It's usually low risk. So you can have carcinomas in your sinonasal cavity that are non-keratinizing squamous cell carcinomas that are related to high risk HPV, but the sinonasal papillomas are, if they're HPV, they're low risk. And sometimes they even have coilocyte-like atypia. If you have a high risk HPV in your nose, it's not going to create a sinonasal papilloma really. It's potentially just going to create invasive carcinoma. All right, I think that's it. Thanks, guys. I'll let you guys do your meeting.